but really excited to have a chance to interview you, Rebecca, and get some thoughts from your diversity of experience. I won't go through your stunning biography because I think we covered that really well in the invitation. But you're so perfect to talk to this because you have your hand in sort of a triad of really relevant experience. Your work at Ariadne Labs, which I think is sort of research and policy advocacy to support policymakers, administrators, even the general public to understand best practices as it relates to sort of urgent healthcare issues that come up. And so that sits sort of at the intersection of public and private sector. You're an active clinician seeing patients at the Brigham. And then you're also a VC that's supporting young startups in this space that are also responding and working in pandemic world and shelter in place and trying to make their own best practices as it relates to vaccination for their employees and such. So I thought maybe we'd start a little bit with your work at Ariadne and the many-fold activities there. If you would talk a little bit about that. You guys have been doing a lot since the pandemic hit. The vaccine allocation planner, the distribution versus administration tracker and visualization work that's been really cool, the manufacturing predictor, and then sort of serving as an ad hoc and consistent policy advisor. So maybe just share a little bit about what Ariadne is and your role there and the goals from that organization as it relates to the rollout.
Please, Dan, really hoping this can be a dialogue because I can tell there's a lot of expertise on this call. So I have some open-ended questions for you all, because I think very much this is a new market forming where the assumption was we would have no supply of a vaccine within this calendar year. And in 2020, in February, I said out loud, we need billions of doses of this vaccine produced in the next 12 months. And that was kind of brushed aside, and I can share with you my inbox of there's no way a vaccine will be approved in 2020, Rebecca, or we will never have the manufacturing capacity for billions of doses. And it's in a sense that mindset, if we think of kind of all the bureaucratic structures that haven't upgraded, that we ended up with such an incongruous relationship here between discovery of the vaccine, for example, its development, and then its delivery. And I think like all of you, we all obviously at Ariadne see this as an arsenal of tools. So the early work at Ariadne became about what is the evidence based on masking, and a tool, and several of us wrote pieces kind of reminding everyone that this was evolving, but it was quite clear that we need different forms of masking throughout the pandemic, testing, social distancing, and obviously the vaccine delivery as well. So it's been kind of a striking moment, I think, for everyone because of the realms of disruption. And it's very much been compelling to see our entrepreneurs kind of rise to this challenge, find solutions, and then how do we think about the ecosystem they need to flourish in the midst of the disruption.
So when you guys set about to think about the question about vaccine allocation and that problem, knowing that there was going to be a supply demand delta, talk a little bit about that initiative and reaching out to the various different experts to begin to put together an allocation planner and the audiences that were going to receive that and potentially use that to actually think about an ethical rollout, an equitable rollout, and all the constituents that needed to be considered.
Yes, maybe, and I'll just take one step back to explain the COVID-19 prediction model, which we started in April and May. So with our friends, Prashant Yadav, who's my close colleague for the last 10 years, knowing how promising the mRNA vaccines would be, we realized countries would likely be procuring a portfolio and that so many countries wouldn't be able to procure this first generation of vaccines. And so what the model does is help you, in a sense, predict which vaccines would end up getting to an approved regulator, and then a deterministic model attached regarding the manufacturing capacity that we had available. And what's been striking, I have to say, is that our predictions are more conservative, which tends to not happen in a moment like this. So the model helped, obviously, and it got better, obviously, as we started seeing the phase 2 trial data But also what's been striking, I have to say, is the horizontal cooperation. So Novartis obviously offering manufacturing capacity for the mRNA vaccines, Sanofi and GSK as well. So acknowledging that aside, we had to then think of, even within the United States, even if the press releases were saying X supply would be available, we knew this would be in a sense of a bullwhip. The press release would say X doses, but the federal government would receive Y. And in this phase in December in particular, we were thinking through how would states then manage as they were waiting for that signal of how many doses they would receive. And I'll kind of then pull ourselves back. So this is now August of 2020. The states are waiting for guidance from Operation Warp Speed regarding their supply. And what became quite clear was that they would not receive direct guidance. You'll receive this many doses this week, but there would be kind of press releases regarding federal procurement versus state allocation. And so Bill Foege, who was one of the folks who led smallpox eradication, and Helene Gayle started putting pressure on Operation Warp Speed that the states needed additional guidance. They needed to know in advance to prepare for what we thought would be January or February of 2021. And so the National Academies and Victor South set up a group called the National Academies for Science, Engineering, and Medicine regarding the equitable allocation of COVID-19 vaccines. And so we were basically in those meetings and took that massive 100-page report and created a tool so that states could immediately begin that planning based on the National Academy guidelines. It's public and open if any of you want to see. There's a lot of data wrangling behind the back end of it. So if anyone wants to go through the that exercise, please to have a spin-off conversation, because all these allocations were then based on 2018 census data, which we determined would be leaving out subpopulations that hadn't been captured in census and labor data. So additional work was needed. But just to note that all states were then required at the first week in November to fill out a CDC playbook. Truly, this is how I, as a state of California, if I received X allocation, this is how I will actually distribute it across the state. And luckily, we had done the homework for them. So they utilized the planner to fill out really that first page of the CDC playbook so that they could then, in a sense, create a detailed plan. And now, unfortunately, what happened 3 weeks later was the CDC had the ACIP meetings, and the ACIP changed the order of the priority populations. And so we went back to our data wrangling effort, showed the difference between the National Academies and the ACIP, and then created the planner so you could choose either guideline as you'd be thinking about how would you demonstrate in this early phase your distribution.
So then how's it going? You know, when I look at the headlines, you know, here you are then stepping out of your Ariadne work and going back to the Brigham, and the Brigham is doing its vaccination for its personnel. You receive your vaccine as a provider, and it's rolling out the vaccination for all the workers as well. And we know from just reading the news that there are a lot of unaccepted doses at the personnel at MGH and at the Brigham. A lot of minority healthcare workers chose not to receive their vaccines. And we also know from state headlines that among the vaccines given in Massachusetts, only 3% are African American, only 3.6% are Hispanic or Latinx, compared to 45% being white. So it's not going well. And the doses administered versus distributed are not nearly parallel on those curves. So how is it going in the states? Maybe just talk about Massachusetts, and are they using one playbook versus the other? And the numbers reported to the CDC versus to the state are also discordant. So what the what?
Yes. Well, pleased to also, if anyone wants to go into deep details about all the reporting lags, I track it day by day. And we also have to think through, this is a system that hasn't been upgraded for decades. Immunization registries, there's 64 immunization registries, some cities, states, territories, and the digital infrastructure cannot manage this moment in time. And we made this very clear in October and November. Actually, the CDC director at that time, Redding, made it very clear we were not prepared with the information infrastructure. So what we're seeing today, you're absolutely right. I mean, the monitoring is insufficient. It's not timely. I will say it's getting better every week. And those of us who look at this data every single day I want to kind of put a mark in the sand that this week will be the first week that the states receive 3 weeks of notice regarding the supply that they'll receive, so that they can feel confident about setting up their scheduling for first dose and second dose. And it was very unclear, and just the messages, I'm sure someone's going to write their dissertation and books about this later on, but I just have to share, when it can be public, the states received such conflicting information about the supply that they were going to receive. And so the states that were very concerned that they were raising expectation and wouldn't be able to fulfill it had a sluggish start. The states that said almost, forget it, we're just going to like go full hog and assume we're going to get replenishment. You do see momentum different, but that's a very different state leadership mindset, which you're seeing play out in this effort. I think the second thing that is complicated, Nina, when you're talking about health systems first and who had the freezer capacity and who is able to distribute it, as such, it is a complex issue regarding Pfizer and Moderna. I think that's also going to be solved, not just only with the Johnson & Johnson vaccine, but we're going to start seeing stability testing of the Moderna vaccine that won't require this level of cold chain and administration protection. Yeah. I'm always keen to, my state has a lot of issues aside, but I'm also eager to talk about states that are doing a great job if people want to hear about beyond the Massachusetts-California corridor.
No, and that's important. And I also wanted to put a pin in the topic of that digital data infrastructure and ask the question, Wendy, for example, my partner, has been working on an Alaska coordinated group that includes some folks from Microsoft, and Microsoft, Salesforce, Viva, Amazon. These are folks that have solved for digital infrastructure and real-time visibility also into distribution networks. You have folks like Federal Express that have laid incredible pipeline for understanding, real-time sort of control tower visibility onto where a package is. You have pharmaceutical distributors that have been making it work in our industry for, medical distribution for decades. So why, if the private sector has all of this capability, has it been so difficult to give states visibility onto the supply chain and the timing? And is this a failure of, the public sector and the private sector being able to work well together?
Yeah, I do think Operation Warp Speed made it. They had no bid contracts for Deloitte. Had the ability to build vans. Palantir had the ability to build Tiberius, and even with the New York Times and the Washington Post and a whole group of us that have worked to try and say, could we help improve the algorithms and improve the data visibility? We had no response from these entities. Obviously, in Operation Warp Speed in the fall. So. Number one, I just have to say the level of transparency and the access of the COVID-19 response team now is so much better. They're taking input and want feedback. And this became, a default to the states. So individual states were able to contract and bring in that type of expertise. Washington State from the beginning actually created their own system, who I've been in contact with regularly, and decided not to go with an outside vendor to think about how do they allocate. But for example, West Virginia contracted with a group called Everbridge to create a pretty instantaneous messaging system regarding leftover vaccine, identify where people are, who needs to get vaccinated. So we're seeing this decentralized, because the moment has become so decentralized and the states were unprepared, you're seeing different states come up with either just-in-time inventory, ways of messaging, ways of tracking. What did not happen was using all the capacity we have in the private sector to do scenario planning as we had this dynamic supply.
In the distribution to the states, because it's been really a state coordination, it's trickled down to heavy reliance on county and city public health departments. And then, as you said, I think because of the reliance on the freezers, also coordination with the larger health systems that have that capacity. It seems like, particularly for equitable distribution and overcoming vaccine hesitancy in communities that may be more reluctant or adverse to vaccination, that there's been a real missing link to community health and to the federally qualified health clinics or those organizations that are more closely working with less enfranchised patient communities. Do you think there are efforts that are beginning to link to that? And for example, what you just shared about West Virginia and the sort of instantaneous text messaging or whatnot for leftover doses that are beginning to take root?
Yes, absolutely. I mean, yesterday, Andy Slavitt said, 1 million doses are going out to community health centers. And so we've been helping, for example, in California, the federally qualified health center prepare. What does it mean to actually involve COVID-19 vaccine in the midst of your routine delivery today? It is, someone has to self-attest to their eligibility. They have to sign up for the first and second dose. And so that preparation phase has been very narrow, but the doses are coming. And the responsibility to then administer and get those shots in the arm quickly is something that these federal are taking seriously. I also think it's an incredible moment for many primary care providers. They want to get involved. They want to actually think about the lag in preventative care and use this as a moment. Here I am, your trusted provider, giving you the vaccine. And let's talk about all the health maintenance and the lag in your care that we can begin discussing in the midst of the resumption of care.
How has it been going in your own sort of clinical care in the vaccination clinics? What is your person on the street experience there?
Oh, I mean, if I can offer a ritual to everyone to be able to volunteer at a vaccination site, it is absolutely healing. It's the first time I think, I can't even think about how many nights, but after many nights of doing night shifts in PPE and not being able to directly see a patient in their eye because of so much garb and schwitzing underneath, to be able to make eye contact with one of my colleagues, and protect them has just been incredible. That was in early December, and a lot of emotional release and stress release during that time, and a lot of sense of inequity that we were able to access this vaccine that had been tested in our own hospital. We ran the Moderna trial, and then we're actually providing it for the workforce. And now, obviously, vaccinating part of our patients via Patient Gateway, we were reaching out to patients, has also just been as stunning as people talk about, the resumption of being able to maybe see their grandchildren outside. And as that notion of really digesting the stress that people have been experiencing.
Can you both describe exactly how Brigham began the vaccine rollout in terms of, planning and considerations and who would be vaccinated first, what it looks like? And then as you're moving beyond the providers and the staff and into the general public, who is getting, where are you in the tiering of vaccination? And then also talk a little bit about how people's lives and behaviors are changing post-vaccination, what you're seeing people think about in terms of post-vaccination experience.
Well, I have to say, I am not holding up the Brigham did this well in this conversation. I know this is recorded. But I want to just acknowledge, the lack of planning, even a system like a teaching hospital in Boston, where we knew about the trial results, the trial is being running. This literally was 24/7 work for occupational health to get up and running. And so kudos to that team that worked incredibly hard. And once again, even the Brigham and all the hospitals in Massachusetts did not know the exact number of doses they would be getting of Pfizer and Moderna. They weren't even given the tracking number from UPS to know when the shipment was going to arrive for security reasons. And so you had to have security on our delivery back truck end meeting, waiting for the delivery to happen. And, there's been deliveries where people aren't sure, where's the driver on Sturo Drive? Have you ever been stuck in traffic there? It's got everyone quite concerned. So just have to acknowledge how little information was made available. It was clear, providers that are front-facing patients would receive the vaccine first. That became a little complex to administer. So every hospital system did this differently. We had an online system that opened at 3 p.m. on one day, and that created an access problem. Not everyone can access the internet at 3 p.m. on a certain day, our night shift workers versus our day shift workers, so on and so forth. So there was definitely, some inequity and, a rough start. I think many health systems had that, but the workforce, those in the workforce that are front facing who wanted to receive the vaccine, it's all been made available to them. And then not by the choice of the Brigham, and I've spoken about this with the leadership at the Brigham, but they were given instruction from the state to complete the supply that they had for the workforce before proceeding with patients. And that also was deemed as, not something many providers want to see happen either. So acknowledging kind of the lack of a full state level conversation because of just the few days they had to prepare in early December.
And having to complete the supply, that meant that there were individuals who weren't necessarily in the provider or staff community or cohort that were given access to those doses because they needed to be used.
I would just say it was like a generous interpretation of what it meant to be part of the workforce. So we obviously have a provider network that sits outside the actual structure of 75 Francis Street. So many of our outpatients we wanted to bring in, it took some time to access them. So in the interim, you can imagine the administrative staff that is interacting with the patient, but not maybe providing clinical care for the patient.
Sure. We have a couple of questions. Yeah, go ahead.
I just want to mention that, there's a lot of media about the line cutter. And in December, we worked with the New York Times to create an interactive graphic called Find Your Place in the Vaccine Line. And the idea of building that for the general public was actually to have you understand my place may be further back and I'm protecting the person in front of me. And I am overwhelmed with the number of Americans who've reached out to say, I understand why I am further back in the vaccine line. And I do wish we would start messaging and talking about all the people who've been patient, those who can maybe sit at home on Zoom, our knowledge workers, for example, are working hard to get their parents in for a vaccine, but know that they would be later in line. That's the majority of Americans. And I just do worry sometimes that the media, it's clickbait to talk about the line cutter versus acknowledge the patience that many Americans have had and displayed to ensure that we'll protect the most vulnerable, which truly are those over 75.
I think that is so true. And I think the other thing that that we perhaps don't emphasize enough, and this goes to one of the questions from the group here, is the reassurance about the timeline to get to when everyone will be vaccinated. And do you have a perspective on sort of when is it likely that anyone who wants to be vaccinated can get access to their first and second dose? And how far out are we from that, available supply?
That's a great question. Should I answer Karen's question first
maybe
in the chat, or?
Yeah. So maybe take the when do we arrive there, and then we can come back to the differing guidelines. And I think within that also, you had mentioned, everyone over 75, but I think there's sort of also, we can maybe dig into a little bit, who is the vulnerable and where does equity fit inside of that. But let's begin with how far are we from everybody having access, and then let's get deep into the guidelines.
Yeah. Actually, so if folks want to pull up, there's actually a great graphic in the Washington Post today. So the data wrangling from the vaccine allocation planner that we built with Sergo Ventures helped power these graphics at the Washington Post, and it helps you do that sliding march. So if we increase the rate of vaccination to 2 million a day, 3.5 million a day, when will we reach herd immunity with the vaccines we have in the portfolio? And obviously, one of the most significant variables ahead, which we're waiting for next week, is will the Johnson & Johnson one-dose vaccine be approved for distribution in the United States? Because of obviously its ease of administration, of it leading to immunity 4 weeks later, that obviously we can speed up that timeline. The second thing that's just been absolutely striking is immediately from taking office, the Biden administration started working on horizontal cooperation for manufacturing, literally helping Pfizer and Moderna think through any ways that the federal government could be involved to improve the speed of production. And there's just been incredible outputs from both companies that, yes, they're finding ways. And here are the ancillary products they need. What does happen right then is that we have a different implementation bottleneck. So if I show you the map in my room, it keeps changing. So now it's the syringe, right? We need a low dead weight syringe to get the 6th dose out of the vial. And that syringe company is not ready. But the speed and the access to the ability of the federal government to think about what resources, what other companies can we bring in, it's just happening at a pace that's truly like a wartime production, and using the capacities of the private sector to respond. So I do think this is so dynamic that it is very hard to predict. I'll also just say all these vaccines prevent hospitalization. All of them prevent severe disease. So when I'm talking to most patients, I recommend if you can get access to a vaccine, get it. It will help preserve and protect you from being hospitalized from COVID-19. You may need to get a booster because of the variants. We'll see, but I think what will end up happening is the general adult public will have access to the vaccine. Anyone who's interested, by fall 2021. Other caveats, obviously, are immunocompromised patients that can't host a response, children under the age of 16. There's just much more clinical data we need to serve those populations.
So let's talk about why the federal guidelines on who's eligible differs versus state and local guidelines. And then I think on the equity side, there's been, some real debate about whether or not, protecting someone over 75 when, the comorbidities and the morbidity of COVID in certain racial demographics is so much higher, even in younger ages. And so is it really by age or should it be by race, is relevant. So maybe you could discuss a little bit about the algorithms and the guidelines.
Absolutely. So Karen, thank you for your question. I mean, this is back, once again, unfortunately, this is traditional public health where the federal government does not get involved with saying X person should receive Y when a product is scarce. And this is actually state law. There are state laws regarding who's allowed to turn a guideline into a requirement for reporting, which unfortunately is now hung on these immunization registries. So each of them has a different feature set. It's literally like 64 different EMR systems that then the federal government's trying to understand how to monitor and report. But once again, I think this could have been a moment when Operation Warp Speed set up not only guidelines, but requirements. And to respond to those requirements, you could have factored in vulnerability to COVID. So in October and November with Parag Parthak, who's at MIT, he's an economist who's an allocation expert who thinks about kidney transplantation, for example, school choice. We began thinking through what are the indexes you would need to index to COVID-19 vulnerability, both because of your risk of COVID, so age, comorbidities, for example, and your exposure. So your daily job requires you to have interaction with the public, for example. And that was actually what we built into the vaccine allocation planner so you could scenario plan. And what's clear actually is if you factor in the social vulnerability index, which the CDC's used for other, it actually is quite similar to using race, ethnicity, zip code. So we already had a known standard to use. So the CDC would prefer to use an index they've tested for other emergencies. And so the guidance from, at that point, the national academies was you should reallocate based on the social vulnerability index. So certain states have done that. And that's what's been striking, I think, in this moment, Nina, where Tennessee, for example, redeployed 20% of its vaccinations from one county that did not have as much vulnerability to the highest hit county in Tennessee. And I think these are these moments of adaptive leadership that is a state by state decision. I wouldn't, I'm not advocating that. I'm just acknowledging this is where we are. And so it becomes the decision-making process of that health commissioner and the vaccine advisory group.
But some of this will get legislated, right? I think there are some, for example, there are some unions that are challenging the allocation guidelines, because they feel like their employees or their members are being left behind or inadequately accounted for in the guidelines because of economic vulnerabilities.
Yeah, I'm not, I almost at this point that the level of, I mean, Uber's done a phenomenal job of advocating for their drivers, for example. So the gig economy is represented through many states. So in a moment like this, where we're facing scarcity and decisions need to be made quickly, probably legislation is going to fail us. And I think the Biden administration's decided we just have to improve production and manufacturing, and we're in this temporal moment of scarce supply. And I agree with that. I actually think we're weeks away from having a sufficient supply to meet demand, and it's going to be this dynamic demand where the vaccine's available in your community, and we need to bring this early majority that's wait and see to a convenient place to receive the vaccine. So I'm not to put aside our lawyer friends, but I think this is going to have a lot more to do with leadership and communication and opening up the right delivery channels to meet the demand locally.
What are you seeing or hearing? I know that you've been also very close to some of the discussions of national policy setting and also the formation of the new administration. Your network is very rich with folks who are leaning into to help. What can you share, if you can, about some of the initiatives to do just that, to set up sort of new sites of delivery and overcoming some of the obstacles like the 15-minute observation period post-dosing or the freezer and refrigeration? The J&J vaccine would obviously be a big milestone there, but I'm sure there are an awful lot of voices and individual contributors wanting to help bring pharmacies in or other sites of delivery. Any?
Well, so I mean, two things. One is the retail pharmacy chains have all been involved since November. So we've been on the phone with all of them, the major ones. And they actually preferred to have had more direction from the federal government. And to think, again, a retail pharmacy chain is not used to responding to a pandemic. They can provide convenience care, they can provide a consumer product, but ensuring that this isn't a transaction, but a dialogue with the customer about the vaccine, about the second dose, monitoring for the side effects, that's actually really beyond the service delivery of most retail pharmacists in the supply chain. So I have to say, I've just been incredibly compelled by all the companies want to do this right. They wanted to think about which stores do I open first, which stores needed supply first. And many of the chains used an index. Second, they want to expand the notion of who could be a vaccinator. So a lot of folks are working hard, and I'm pleased to share with you the scatter plot of certain states. For example, veterinarians weren't allowed to vaccinate. Well, we challenge that. Veterinarians know how to put an injection, and medical students, nursing students, there's a whole host of people that we could upskill in this moment. And I think all of that is going to be a very temporal moment that people are going to see. We can actually expand the vaccinator workforce and then allow, a non-trained individual to do the supervision and surveillance of that 15 minutes with a nurse or physician or an EMT with oversight. So I think, in a sense, the vaccinator is going to be a wider group of people, and that bottleneck I don't think that's going to be a persistent bottleneck in a few weeks.
So Wendy asked the question of, with unleashing the manufacturing supply, why will it take till the fall? What are the key bottlenecks to satisfy? Why will it take till the fall to reach wide implementation?
First we're this is projections from the companies that they can get all this horizontal cooperation up and running, only estimating for the mRNA vaccines. This is assuming Johnson & Johnson does not get approved, nor Novavax. So could we vaccinate the American public with mRNA vaccines? So that is truly why. And it's the second, this is the good and the bad of this, right? We have to realize that the procurement and the contracting of doses has already been out to bid. So Pfizer has significant requirements to fulfill for other countries. We have to think about our relationship with COVAX and the global responsibility. And then there's countries, for example, I think as many of you are following, Israel was able to sign a very early contract with Pfizer in exchange for its data, which secures their ability to receive supply. Canada has procured 4 times more doses than it needs for its population and is participating in COVAX and getting a discount. They've been very aggressive. So, Pfizer can choose, right? They're actually in this marketplace and have that management capacity to manage that, versus Moderna, obviously receiving direct capital from Operation Warp Speed, has a different relationship to supply Americans first.
I know that you mentioned the line jumping phenomenon, and I think there's perhaps concern and judgment around individuals positioned to do that or wealth. But do you see a situation in which I'm sure you've had inquiries in the venture hat that you wear, in which companies will try to seek access for their entire staff, the way that so many startups were able to facilitate on-site testing with regularity and frequency to get fully back to work?
I've seen that more with large companies. So I speak monthly to the folks who involved in Castlight Health and all the employers that come. So since September, that's been a question, for example, that large scale companies have had: should I begin procuring doses to protect my employee base? And that was decided that's not the right way forward for a whole host of reasons. I'd have to say what we've been incredibly, is another outlet here, and it does answer, Wendy, part of your question, is we do need more delivery channels now. And so the employers have come to say, I will open up vaccine sites like I normally do for the flu vaccine. It's been unbelievably generous. People say, I'll offer the infrastructure, I'll pay for the vaccinators. And so I think that's going to be a very important channel for not just obviously their employer base, but their representation to the community when we're talking about Boeing, AT&T, so on and so forth. So if those can be deployed, I think that'll just, in a sense, expedite the timeline.
But it will align with what the actual state rollout protocols are and sort of reaching into that general public access and availability.
That's correct.
Yeah. Do you think there's anything, in that vein, anything that we as venture investors or venture companies can be doing to increase, vaccine enthusiasm, vaccine acceptance, support for reaching herd immunity?
That's a great, first, this is such a monumental communication task in many ways, to explain the science of a brand new vaccine on a platform that people may not know the vocabulary behind it. So I think you're probably all consuming, folks who are doing an excellent job trying to communicate why these vaccines prevent hospitalization, why these vaccines prevent severe disease. And so I think having this message out that this is what we know about the science today, and I have confidence in the science from folks who have scientific backgrounds of your caliber, it reinforces that message. And, I think we're going to hear about adverse reactions. We have to think of what's the denominator here when we're deploying millions of doses of the vaccine. Actually, the adverse events are less than the clinical trial at this point. The Moderna team's actually quite proud of as few reactions they've had as we've gone into this stage. And then the second, I know, there's disparity in the uncovering of disparities that we've seen through the pandemic. The vaccine's just revealing those, and vaccine access is revealing those, but they're obviously much more related to how our health services and health systems are structured, people's lack of trust or ability to access a provider, or how they think about their health system per se. So it is true. The data behind this is a local decision that people are actually asking their neighbors. They're going to their clergy. They're going to those in their inner circle, and they would prefer to receive the vaccine in close proximity to where they live. So I think we're going to start seeing this hyper localized, I hope, distribution that will actually, in a sense, show that equity, if we build in and we structure delivery systems with equity, we actually start then improving population health.
And do you think that getting to broad scale population vaccination by the fall of 21 is sufficient to achieve good coverage against evolving new strains? Are we racing fast enough against the clock?
No, I mean, I would say, and there's a great graphic in the Washington Post about this today, that this is why people have been, this is the difference of 1 million doses a day versus 3 million doses a day, right? With speed, we actually will have fewer variants. We'll actually be able to, in a sense, not have to think about and reformulate for the boosters. And so the pressure right now is, can we actually increase? And I do think the supply is going to be there. So this is weeks away, but we'll get there faster if we start vaccinating faster, which means opening up additional delivery channels.
Well, that's not the most optimistic note to close on. So I'm going to lean on my friends and colleagues here to see if they have any other questions that let us get onto an upslaying. Gang, thoughts, questions for Rebecca?
Rebecca, I would just say, from my standpoint, most of us are very anxious for our ability to bear our upper arm and have that needle find it. And we're very privileged to have this opportunity to hear from you, and really appreciative of the work and probably the long hours and sweat and tears you're putting into this effort, because and I think the one place I am quite encouraged, because it feels substantially different, at least from the media and from communication, is the difference with the Biden administration. That it feels like we may finally have a fighting chance now. And it seems like your knowledge on the ground, you're confirming that, in fact, and that's not misplaced confidence, but that we have competency, we have data at work, we have, given the shambles this was all in terms of a response, and that we're finally getting our feet on the ground and being able to deploy the massive intellectual and manufacturing capability of our pharmaceutical industry, which is great. So, I really appreciate your efforts, and I think it is very encouraging to know that it's not just misplaced confidence, that we're really starting to get there. And I wish you had said we'd all have access by June. So we're all going to June, not for September.
No, it truly does feel like, to the extent there is an agenda at the national level or the administration, the agenda is public health and science and equity, and not any self-interest. And it really feels like the folks that are being drawn in to lead are leading with a sense of unity and purpose, and getting us all back out there and together again.
Absolutely. I mean, I have to say, there's, like a daily scrum of the states being able to say to the federal government, this is what I need. This is my plan. I'm going to deploy it this way because I know my state well, but I need the following. So that means I need FEMA to do X. I need the National Guard to do Y. I need, these syringes to come in 48 hours. And there was no dialogue before. It's hard, I know this is being recorded, but I'm just sharing with you, like, the states were left alone after they've been beleaguered for the whole pandemic. They're chronically underfunded. And so I've very much been trying to highlight some of these state leaders. In almost every state, there's a phenomenal rock star who we need to plaster their names up, who's, articulated their strategy in the same way that your entrepreneurs would in front of you, that type of scrappy, gritty person. It's just, they haven't had the type of capital they need. which is information at this point to plan ahead.
Yeah,
And
a willing ear. Yeah.
The other thing I think is striking is, there's a true understanding of what health equity means in this administration. And equity is not a holdup. It's not a delay. It's actually the fastest path to population impact. And that's where we're going to suppress the virus. That's how we're going to suppress the variants. And that understanding of population dynamics, public health, epidemiology, the experts are kind of front and center in that leadership circle.
That's amazing. Well, enormous thank you for your time, and more than that, for your leadership and your work on behalf of healthcare justice. And it's great to hear from you. Great to be with you. Thank you so much for your time. Such an inspiration.
Oh, a treat to be with you all. And Nina, I've definitely gone to her in moments of doubt and, why are we not able to make this happen? And this is kind of, once again, where you just fall on the people you trust to ask for advice and kind of steward many ships. And I think the level of transparency y'all are going to see in weeks ahead. I hope Wendy's going to give you much more confidence to think about your summer planning.
Getting our Fauci ouchie.